My name is LJ Stambuk, and I'm the President and CEO of the World Affairs Council of Charlotte. Today, in the World Affairs Council Distinguished Speaker Series, we have with us Dr. Derek Raghavan, who's the President of Atrium Health's Levine Cancer Institute. He's going to speak to us on cancer, COVID-19, and confusion. Let me just say that usually I present the biography of the person that we are having as our guest. This time I will not be doing that, as I don't know if there's anyone who doesn't know Dr. Derek Raghavan. He's a good friend, he's a great asset to our community, and I just want to say at this point of time that you might remember, but last year at this time, May 21st, Dr. Raghavan was the recipient of the World Citizen Award 2019, where we had a record sellout crowd, and I'm delighted to welcome you to our World Affairs Council Distinguished Speaker Series, Dr. Raghavan. The podium is yours.
Well, good morning, or good afternoon, I should say, and I very much appreciate the invitation to talk to you. I should warn you, as can only happen in television land, there's a helicopter landing at the Sanger Heart and Vascular Institute next door, so you may hear a little bit of propeller blades going, and I apologize for that, but we'll take care of all of this very quickly. So,
thank you, Derek. If I just may add, this is recorded. The speaker series today is recorded, and we will have the recording available to all who have participated today. And if they wish to share with other people, that will be available as well. Go ahead, Dr. Raghavan.
Okay, so thanks, LJ. So hopefully we won't have too many helicopters landing here, but my plan is to kind of follow on from my friend and colleague Dave Calloway, who I think is a member of your board and gave a presentation to introduce you to coronavirus about a month ago. And I've listed for you the agenda of topics that I wanted to talk about. For those who didn't have the wisdom to listen to David earlier in the month, I'll give a brief introduction to this virus and then really focus on my area of interest, which is what's the implication for people dealing with cancer. So the coronaviruses are a group of viruses that occur in animals and man, and the tricky part and the bad part is it appears that in December of last year, a new type of coronavirus arose in Wuhan, China. It is said variously that it was passed somehow from bats to human. There are always conspiracy theorists when anything bad happens, and some people believe that it was a Chinese plot and that it started in a Chinese laboratory. I personally think the bat story makes a little more sense. Importantly, it has an incubation period of 2 to 12 days. And the new coronavirus often causes respiratory symptoms. It's a little bit scary because this first case report was in Wuhan in December of last year. And then within 3 months, it was declared a world pandemic. I've shown for you a model of what it would look like, magnified hundreds of thousands of times. And on the right of the screen, what we call an electron micrograph. It's a 20 to 50,000 times blow up of a viral particle. And you can see the crown-like top of the virus, which is where the name coronavirus came from. Many people have questioned since last December whether this is a random event and whether it's an important and dangerous virus or not. And my answer is very simply yes. One of the real challenges that we've had in recent months has been the amount of misinformation being distributed to the community at large. And we'll come back to that when I cover the controversies and the confusion. But the reality of this situation is that this is a dangerous virus. I've got a slide here that shows you the world figures and the figures from the USA. But I think there is a very important message in this slide. If you look, for example, at Florida and Georgia and South Carolina, and I've given you their population figures, I've shown you the number of cases that have been identified, but look at the death rates. I don't think the number of cases is a very important index, because that just simply represents the availability of the test kits. And if they aren't available, there'll be less cases identified. If they are available, there'll be more cases identified. So the way I think about it is comparing the population of an area with the number of deaths from coronavirus. One of the myths that has been out there variously has been the thought that people are either inflating or deflating the number of cases of death. I don't actually think there's good evidence to support either of those hypotheses, so I think these figures are real. The best figures in the world, to my knowledge, were derived in Taiwan. They have a population about double ours, and look, they've only got 429 cases recorded. That is as of this morning. I updated the slide this morning, and they've recorded only 6 deaths. Many people have described the figures from New Zealand. I think that's partly because Jacinda Ardern, the Prime Minister of New Zealand, is a particularly compelling and attractive speaker. But in addition to that, they also have a pretty low death rate, and they've worked very hard to control the infection there. In North Carolina, and particularly in Charlotte, we really owe a debt of gratitude in Charlotte to the Mecklenburg County Commissioners who locked us down very early. Now, my wife, Judy, who's a realtor and has not been able to practice for the last several weeks, is less pleased with them as a realtor than I am with them as a physician, but I think they rock. The commissioners closed down Charlotte, and as a result, we really have done, by comparison with many other parts of the USA, particularly New York City and Florida, we've done remarkably well. And Governor Cooper is to be thanked for following the line of the commissioners very, very swiftly. I don't doubt that he followed them directly, but in timing, the commissioners closed down Charlotte. Shortly thereafter, the governor closed down the state. Let me be very clear. I completely understand the pain and suffering economically that all of this has created. But the reality is you can't be hungry and you can't be poor if you're dead. And so the reality is, for us to escape from this cursed virus, we have to be alive and in good health. And so, as I'll talk about in a few moments, the reentry pathway will require us to address the economic crisis we're facing, but at the same time to do it in a safe way. And the point I'm making with this slide, if you look at South Carolina, Georgia, and Florida, none of which has observed the tight controls on population, on social distancing, on wearing masks, and so on that we have in our state. Look at how much higher a death rate per capita there has been in each of those states compared to North Carolina. So this is a really important educational point. And I'm sure that my colleague Dave Calloway will have said the same thing some weeks ago. What he would have predicted when he presented to you has been realized. The people who have observed social distancing have had much better outcomes than the people who haven't. Now let's talk a little about the clinical features of this disease. There's some defining features. Contrary to what has been said widely, there is and there was a shortage of testing capability, whether it was a shortage of labs, equipment, the little sticks that you pop up your nose, and I'll show you a picture of that in just a moment. It varies from place to place, but the reality is we have not, until the present time, been able to test anybody that we thought was appropriate. And so we had to identify the most important features that would make us suspicious that someone required testing when we didn't have enough test kits. And they were an influenza-like illness that we abbreviate ILI, with a fever above 100.4, that in centigrade units, I guess, is higher than 39, a cough and shortness of breath. People in long-term care facilities, the homeless, and being in prison were at increased risk. If you recall back to when this started in the USA, in Kirkland, Washington, it was actually, there were 40 deaths in one nursing home that made us suddenly recognize this was serious business. Other people who are able to have tests are adults who are at a clinic or a hospital and for whatever reason unable to give a history, and then hospitalized patients who've suddenly had a stroke or the blockage of a large vessel. And the reason for that is it turns out there is an increased coagulation of the blood in association with having coronavirus aboard. Other symptoms of importance, one really interesting one and not fully explained, is that people who've had coronavirus have noticed a loss of the sensation of either smell or taste or both. Now, L.J. Stambuk, our beloved president, would find that intolerable because of his love of fine food and wine, but nonetheless, that's one of the features. In addition, occasionally people will suffer from diarrhea, headache, muscle aches and pains, and very recently they've added chills as another potential feature that will get you tested. I've summarized here the high-risk group for getting into trouble with this disease: old fellows like myself, people with known heart and respiratory disease, those who have immune suppression, including renal failure, conditions like lupus or SLE, people on medications that suppress immune function like corticosteroids. And then obviously my colleagues in the healthcare worker industry, the first responders. And remember, we shouldn't forget the people who show up at the stores every day and sell us our produce and goods, and all the people who are essential to keep our society going. And again, because they're mostly elderly and sometimes demented, people in long-term care facilities are at increased risk. The whole issue of diagnosis has been pretty important. There has been a lot of political rhetoric about whether testing is freely available or not, and there have been clearly, for whatever reason, some dreadful misstatements. The truth of the matter is routine and widespread testing has not been available in the United States. In fact, in Taiwan, we'll come back to them in a moment, it has been freely available. We simply haven't had the bandwidth to do this easily. The biggest problem, interestingly enough, has not been the problem of equipment. I've even heard the president talk about the fact that there are plenty of labs around the country. And silly as it seems, the little probe that you insert through the nose along the nasopharyngeal pathway, because the virus sits at the back of the nasopharyngeal pathway, those swabs have been in short supply, and the transport medium, in other words, the liquid that you have to put those swabs into to get the virus to survive passage to the lab, those have been the rate limiting step. To actually do the measurement, we take the particles off the swabs, run them through a molecular biology machine that looks at either DNA or RNA that allows us to identify that the viral particles are there. There's been a lot of airplay about antibody testing, and I can comment that the idea of that is that when you have a virus in your system, the body recognizes it as foreign tissue and mounts an immune response against that viral particle. And we can measure both the acute or the immediate response, and we can measure the response over a period of time. And so there are two antibodies, the so-called IgG or immunoglobulin G and the immunoglobulin M, that will be elevated in people who've been exposed. The tricky part is we do not yet know for sure what the levels actually tell us. We know that there are people who have had coronavirus and come through it well. You might have seen on CNN, Chris Cuomo, on other televisions, various other personalities have had it, and they have come through without having to go to the intensive care unit, without getting into trouble. What we don't know is how to measure their bodies to identify which people are going to be safe in the long term and which people aren't. We know, for example, that we can give a vaccination for most of the influenza types, and they will protect us for at least a year. On the other hand, for hepatitis C, antibody response occurs, but it does not protect from reinfection. So it depends on which particular virus you're talking about. And so that being the case, one of the pieces of work that we'll be doing at the Levine Cancer Institute next week is getting a bunch of our volunteer physicians, nurses, scientists, and frontline workers to agree to have the antibody test so we can follow them and see what actually happens when they have high levels of antibody available or don't. Now, one of the things we should talk about a little bit, because there's so much misinformation and it clearly is unfortunately influencing public policy, is what is true and what isn't. And I've called this slide myths, conspiracies, and nonsense. And this, I think, is important enough. I rarely read slides in detail, but I think it's important. December through March, people were saying it will go away when it warms up. There's absolutely no evidence that this virus will go away by itself, and that's predicated on the fact that it killed people in many warm environments. It's been described as fake news and a political stunt, and clearly everybody who would be interested in the WACC would know that that's absolute nonsense. I've mentioned the fact that not everybody could get tested, even though it was being stated publicly at multiple places. It was said frequently that there was no shortage of personal protective equipment or PPE. That's just absolutely false. The reality is, even at the Atrium health system, and remember, we're pretty big. There are 40 hospitals. We have about 60,000 staff, 2,000 physicians. I think we see about 12 million encounters a year. We had terrible trouble in getting the equipment we needed. We went to FEMA initially and asked for some help in getting anesthesiology machines. For our system, we received 2. And we had shortage of personal protective equipment, masks, gowns, and so on. We're incredibly blessed that we live in Charlotte. So one of my colleagues, Dr. Jean Chai, who's one of my leaders at Levine Cancer Institute, happens to have a brilliant daughter and an equally brilliant sister who is a filmmaker. And the daughter and the sister teamed up. They went to Charlotte Latin School to the 3D printing lab. The leader of the 3D printing lab reached out to UNC Charlotte, to their 3D printing lab, and lo and behold, the Chai Consortium started making facial protective masks that gave us enough for our frontline staff, the courageous people who work in the ICUs and in the emergency departments. We took them at Levine Cancer Institute because we have immune suppressed patients. We even were able to send a bunch to Duke University Medical Center to help them. So forget the idea that there has been no shortage of equipment. I think we're in pretty good shape now. As far as I know, New York City has finally caught up. They had such a deluge, but the idea that there wasn't a shortage, simply not true. There have been recommendations to try the various chloroquine derivatives. There's a lot more evidence that those derivatives can cause cardiac problems than there is evidence that they work. And fortunately, in the last 2 to 3 weeks, the rhetoric about chloroquine has suddenly and magically disappeared. Many people, to the present time, notice that I say January to May, I am forecasting tomorrow. People continue to say that social or physical distancing is unnecessary. And I've just shown you data that support the thought that in North Carolina, New Zealand, Taiwan, where we have seriously taken aboard social distancing up to the present time, it has made a huge difference. It cannot be just circumstance. The rumor that borders have been closed, again, untrue. The Taiwanese closed their borders fully and did very, very detailed screening on people who were allowed in. We have allowed only a proportion of people to be precluded from entry into the United States, and that's why we've had a continuing and ongoing supply of new coronavirus, despite the assertion that our borders are closed. There is continuing discussion that it's already safe to go back to work. Many places that's not true, including New York City, most parts of Florida, most parts of Georgia. And so there's misinformation being given there. The comment that it'll be definitely gone by Memorial Day, coronavirus or the new coronavirus is here to stay. It's not going to go away. Its level will be decreased. And like influenza, it'll be around to capture us unless we're able to develop an immunization schedule. And then perhaps the silliest statement that has been made to my hearing has been the thought that you can use ultraviolet light or drink Lysol or equivalent to make this go away. And I'm not even going to dignify that nonsense with a further discussion. So why are patients with cancer more at risk? Well, cancer is often associated with advancing age, and older patients have reduced immunity. So they are more at risk of suffering from invasion by the coronavirus. Unfortunately, many of our treatments, such as radiotherapy, chemotherapy, some of the immunological treatments, and even some of the new and exciting targeted therapies that attack the genes that cause cancer, can actually alter the way the body's immune system works, either turning it into overdrive or in some cancers, such as lymphoma and Hodgkin's disease and myeloma, causing a reduction of immunity that makes people more liable to this virus. Some special considerations for our cancer patients. Getting a test is not necessarily that easy. I think Atrium Health has done a very nice job in making multiple sites available for testing, but in the situation where there is a shortage of testing reagents, it makes it hard, and the bar to get tested has been high, and I talked to you about some of the parameters of that. The fear and uncertainty of fighting two battles, one against potentially the coronavirus, the second against cancer, is very, very overwhelming for our patients. Patients have been fearful of coming to hospital or clinic because of what they're hearing from the news, and that is an appropriate concern. And then, of course, the impact of treatment, but also the impact of delaying treatment, and we'll come back to that in a moment. I think, frankly, there's been significant stress both on patients and their families and the staff treating them from the lack of defined national and, in some cases, state leadership, with confusing information, conflicting information, inconsistent information out there. I think another thing that's been problematic, particularly at Levine Cancer Institute, where we emphasize heavily the personal touch and relationships, as you'll see in a moment, we've had to change our clinic staffing to deal with this virus onslaught, and that has disrupted some personal relationships and has been tough for our patients. And then finally, the information overload and the inconsistency of information has been hugely problematic. So let's talk about what we've done at LCI, the Levine Cancer Institute. Just to let you know, if you're not familiar with the Institute, we have our headquarters down in Charlotte, North Carolina, and I've given you some pictures of our hallmark building. We actually have about 25 or 26 branches scattered from Whiteville, North Carolina, down to Rock Hill in South Carolina. We have in the past had branches in Charleston and Anderson, and then out in places like Lincolnton, Shelby, Blue Ridge. So we've really scattered ourselves around to make it easier for patients to get treatment and not to have to travel into Charlotte. I think you could say we're pretty big. We're about the 4th biggest cancer institute in the country. We see about 18,000 new patients a year. We've done about 100 marrow transplants per year for the last couple of years. We've done some of the most successful CAR-T treatments, chimeric antigen receptor treatments, that are a new type of immunological manipulation of cancer. As far as I know, we and Duke are the only two in this state doing those at the present time. We put about 100 to 120 patients into phase 1. Those are first-in-man clinical trials each year, and we see about 200,000 visits. So we're really pretty active, and I've already summarized for you that we're part of the Atrium Health system. So how did we approach this as we suddenly recognized in January that the coronavirus epidemic was going to be a big deal? Well, we started with a literature review, and unfortunately, there really wasn't much there. The Chinese doctors from Wuhan had a couple of case reports that were helpful. Many of the publications from China were actually in Chinese medical journals written in Chinese, so that didn't help most of us too much. Fortunately, I have two physicians, one who joined me from the MD Anderson Cancer Center and one who joined me from the Cleveland Clinic, where I used to work. Dr. Zai and Sun, who are both fluent in Chinese and have connections in mainland China, and they set up a teleconference with leaders from Wuhan to ask the question, what happened, what did you do, what worked, what didn't work? There's a businessman in town here, originally Taiwanese, and he has connections to Taiwan, and so they set up a teleconference for our team with the leadership, medical leadership of Taiwan, to help us understand why they have such fabulous results. Then my colleague Jubilee Brown, who's the current president of the American Association for Gynecologic Laparoscopy, a mouthful that means doing minimally invasive surgery for women with gynecological cancer, she set up an international webinar where we were able to participate and give some lectures ourselves, but also heard from physicians in China, Korea, Italy, France, etc. And so we were able to gain experience from other centers overseas and also had involvement from people from New York City and Washington State. And then we've been lucky enough, and this was pure dumb luck, I was able to recruit Dr. Laura Musselwhite to my team. She's a gastrointestinal medical oncologist who's been with me for about 18 months. And Laura, before she became an oncologist, spent about 10 years working with Tony Fauci and Doctors Without Borders, and has a lot of hands-on experience with Ebola and Zika virus and HIV. And so she's been hugely important. And then on top of all of that, we've had our tumor-specific teams, meaning the breast cancer doctors and the GI cancer doctors and so on, getting together and looking at the specific issues for each tumor to ask the question, is the patient with this tumor more liable? Is the treatment going to make it worse? And we've used what is one of our hallmarks, the so-called electronically accessible pathway system. I'll show you a picture of that in just a second, where we were electronically able to modify our standard treatment approaches to adjust for the fact that coronavirus might be present. And then, of course, as we're part of Atrium Health, we interfaced with Atrium Health Incident Command. I've mentioned Dave Calloway. He's one of the leaders of that group, and so he and I have worked very closely with other colleagues, working out standard operating procedures, both for Atrium as a whole and then for our patients with cancer. Just have a quick look at this slide. This is from Taiwan, and remember, we've been talking thousands of cases and hundreds and thousands of deaths. Look at the figures that the Taiwanese have shown. Extraordinary. And that's because they have had very, very tight physical, social controls. The borders locked down, really locked down early. They've had integration of their data systems between health authorities and customs and immigration. They've done aggressive screening and travel exposure follow-up. They've done cell phone surveillance, so they've actually tracked where corona-positive patients have gone, and in other words, identifying whether they've stayed at home. They've had fiscal penalties for violating the rules. This wouldn't work in the USA, but it's an extreme example of how to do this well. I don't think it would fly in America, but it does suggest that this sort of approach will provide some protection. And so the meticulous follow-up has paid off with sustained outcomes. So I've summarized here our key approaches. Social and physical distancing is a huge deal. We have everyone wearing a mask, both patients and the staff. We've reduced the numbers of visitors unless they are specifically needed to help a patient, someone who doesn't speak the language, someone who's blind. We're not heartless, but we're trying to reduce the numbers of people wandering around our various branches. Those visitors who are asked not to come, and they're asked ahead of time, are able to sit in their cars in the parking lot and dial in for to the clinic so that they can participate. And we've very, very heavily reduced the number of routine well patient follow-up visits. And we follow those folks by telephone or by Skype. And then we've considered modifying treatment, where what we've done is to look at the risk-benefit analysis. So if I'm going to treat someone with cancer, is the risk of the side effects of treatment going to put them in harm's way? Will they end up getting coronavirus and having to go to the intensive care unit? How much benefit will they get from the treatment? And so that's been an important issue for us. And then we've also looked very carefully at whether we could use our extensive cancer trials unit to actually do some COVID treatment trials, and we actually have started our first one. This slide shows you a picture of one of our electronically accessible pathways. And so this is a standard approach that we use that gives all of our people at all our branches a guideline for how to treat cancer. And what we've now done is modified this pathway for the presence of coronavirus. And as you can see, you can actually just look at this easily just on a laptop, and it helps us. We did so much work early and got so much information and field tested a lot of our ideas that we thought it might be helpful to other centers. And so we've actually, and you've got the authorship here, recently published in the Journal of Oncology Practice the way we've approached it. And we've had a lot of feedback to suggest that people think that the sorts of things we're doing are actually quite helpful. This is a slide from the article that we published, and you can see the way we've thought through dealing with this epidemic or pandemic is to think about our patients pre-arrival, when they're here at the hospital or clinic, and after departure. And so we've worked very heavily on education with regard to the implications of the virus, social distancing, protection of the individual, both patients and family members and staff, and then we've altered our staffing. So, for instance, one of the major steps we've taken is to do an on-call, off-call rotation. So half of my doctors and nurses are patient-facing for 14 days at a time, while half are at home. That ensures that half of my workforce are quarantined at home and staying away from the risk of getting coronavirus. They then alternate every 14 days. And remember, I told you the incubation period is 2 to 12 days. So what we're doing is always ensuring we have a quotes clean population. That has had the downside of sometimes interfering with the relationships. Mrs. Smith shows up, her special nurse or physician isn't there because they're on an off-facing period, and that has been a problem. I will say the people who are at home are not sitting there counting their toes and eating bonbons. They're actually on the phones doing telephone follow-up for the people who we've judged didn't need to be at the hospital in a physical sense. On the medical side, the Latin primum non nocere means above all do no harm. And so what we've tried to do is reduce exposure from treatment, avoid treatment that could reasonably be delayed, delay visits till the peak or surge of the coronavirus period. And we've really adjusted and tried to balance using treatment versus deferring treatment. Perhaps, for example, where you might initially shrink a tumor with chemotherapy and then operate to remove it. In this setting, what we've done is operated quickly to get in and out and get the patient out of hospital, have a delay, and then use chemotherapy after the event to try to have the same impact. So we've thought very carefully about how to make this as safe for patients and families as possible. We've created spacing in the clinic. We've delayed chemotherapy or radiotherapy. We've taken seats out of the clinic waiting rooms. We've lengthened the appointment times so that we don't have a collection of people clustering together in our clinics. We've continued to do clinical trials, although we've reduced them some. Where patients are clearly getting benefit from new treatments, we've continued the treatment. If it's clear they're not getting benefit, we've tried to make that decision early. And we've tried wherever possible to maintain a constancy of support to our patients. As I mentioned, we're looking at a drug called selinexor, which is an interesting new drug that was originally, we got interested in it for our myeloma clinical practice, but there is some laboratory evidence that it kills viruses in test tubes, and so we've started a clinical trial to see if it works. Now, unlike the nonsense that we've heard about some of the speculative treatments, please note I'm making no false claims. You won't hear anybody from my team talking about how good it is until we're sure that it actually works. And so finally, in my last moment, where do we go from here? Well, we're going into a reentry phase. Let me be very clear. Coronavirus is not going to disappear. The politicians who've said it'll be gone by the summer are simply wrong. Its level may decrease some, but it will be there waiting to come back. And having said that it won't go away, we can't ignore the economic considerations. And so we have to re-enter the business environment, but we need to learn from Singapore. Singapore had early wins similar to Taiwan, but they made a mistake. They got confident early. They allowed large numbers of migrant workers to come back from neighboring countries, and they populated worker apartments, and a surge began in those apartments and spilled over into Singapore at large. I don't mean to get into the politics here, but there's a problem in Georgia at the moment with early entry, and this is just from something I picked up yesterday from the internet, but there is a problem in Georgia. They have a high death rate, they have not hit peak, and they should be socially distancing along with federal law. So our reentry approach at Atrium Health and at Levine, we have to have testing capabilities so we can test people for the presence of the virus and antibodies. We are setting criteria for reentry. We will continue to make our patients and staff wear masks and have social distancing. And we're going to be thinking differently for the future. COVID isn't going away, and so we'll have patients who will have virtual consults because we've learned they're not too bad. There's going to be a new pathway, but we have to be careful because there will be risks of a second surge. So what we're going to try to do is deal with a backlog of patients, trying to get them back up to speed with treatment. Timing of reentry will be so important, but it will have testing, physical distancing, and there will be continued virtual visits. So our new pathway will require us to think about the COVID positive patients. We've got a couple of approaches that we're looking at. One is separate COVID clinics. The other is having defined areas in our bigger centers where patients with COVID can be put to be treated separately from people who don't have COVID. There will be changes in social norms, as I've summarized here. And then for supportive oncology, that's all the touchy-feely stuff. It's so important. Psychological support, integrative medicine, rehabilitation. A lot of that will now be done by a virtual consultation. And so the future for us will be a new normal. Things have changed permanently. You'll find that handshakes and hugs with people you don't know will go away, and masks will be part of our environment for some time until we have a vaccination available. There'll be virtual visits that are good and bad. There may well be a second or a third surge, and the economy is going to be a big deal. And we now have learned, to our chagrin, pandemics are a big deal, and we're going to have to address pandemic care for the future. So I'm done. I believe now that I should be taking questions, and I will be happy to do that. I'm just trying to return my screen, which is proving difficult. So Jesse, oh, here we go. Stop share. There we go. So LJ, did you want to make any comments at this point, or do you want me to answer
I just am so impressed. I would like to pose a question to you that you can answer at when you feel is the right moment, but your delivery to patients around Charlotte, I think, is also a very innovative and very humanistic approach to all that you do. So we're starting with the question and answer portion. Jesse Herman, my colleague, will lead that. Please type in your questions in the question and answer chat part, and Dr. Raghavan will be talking to you, conversing, and answering your questions.
Well, I have a bunch of questions in front of me, and many of them come from the very famous and very influential John Gals, who's had such an impact on publishing in this environment. And you always know when a newsman asks you questions, you have to be a little careful. So I'll read his question and I'll try to answer it. So, who has the authority to declare a pandemic, and what is your opinion of the WHO and its efforts? Well, I don't think there's any one person. I think if someone as influential as the President of the United States announces that there's a pandemic in this country, we will follow his lead. I will say honestly, I was very disappointed with the WHO approach and the Center for Disease Control. The WHO was way too supportive of the Chinese approach to disclosure, and I think has given itself a real punch in the nose. I think the Centers for Disease Control actually harmed us initially. They insisted on controlling the development of the assay when there were actually some quite good commercial assays available. Eventually, they figured out that they were not able to produce a good assay system, and they opened the doors up, and then we started to make progress. John also asked the question, how can testing be made more widely available outside the hospital systems? You know, I think there are so many quite solid private commercial labs. This isn't rocket science. You know, you can do tests to demonstrate that antigen testing is reliable, and I think there are many labs now that are doing that. So I think the piece, John, that worries me the most is the FDA, and I'm really a fan of the FDA. I spent several years working on their Oncology Drug Advisory Committee, so I know they work hard. And Steve Hahn, their new commissioner, is an old friend of mine. They're terrific, but they're under immense pressure from the White House to let everything be tested in the open market. And the chloroquine story came from the White House. I don't have a political view of the White House, but I think you must be able to acknowledge they make mistakes. And so what I have said to Steve Hahn is, be careful. Don't drop the bar so low that we're getting false positive and false negative tests. Better not to have tests than to get a false sense of reassurance, or to define that people have a virus when they don't. So, I think quality control for lab testing is pretty strong in the USA. So I think free market available. Somebody has said, whoops, there we go. We've seen the recommendations from Governor Cooper for phase 1, 2, and 3. Is his phased approach, the question just disappeared. So is the phased approach a good idea, I guess is what it said. Yeah, I think it is. I think an important reality is there are different areas that have different levels of penetration of coronavirus. There are parts of places like Wyoming and Montana where it really hasn't been a particularly big deal. And to shut them down, I think, is probably a mistake. What I do think is, this is America. There aren't armed guards at most borders. So, if you happen to be in New York City or in Florida, and my pet hate group at the moment are the dummies who've frolicked on the beaches of Florida and then taken coronavirus back to the Middle West. That's the big problem of opening things up. And so having a phased approach, which includes having a situation where we have people masking and using social distancing as we start to open things up, I think that's going to be important. I put a personal, very strong request to my colleague, Jean Chai. I mentioned him as having created this very excellent plastic face mask that goes down to protect you when you're in direct patient facing. And I've asked Jean, for LJ's benefit and mine, if he could create a model on 3D printing, which has that mask plus a straw, so that when we start going to restaurants, we can actually drink wine and soup without putting ourselves at risk. Are we looking at a future of preemptive testing for the general public if supplies become available? I think the answer is potentially yes, while we don't have a vaccination available. I do want to set a context, and this is a really important one. In the early days, many people said, let's not go crazy here, because America has between 30 and 50,000 deaths a year from influenza. Now, here's the important piece. The vast majority of people who die of influenza are people who've not had the available vaccination. Now, so that's 30 to 50,000. We have now lost 60,000 in the USA from coronavirus. And the problem is we do not yet have a vaccination that works. So that would be a good reason to do as much and as wide testing as we can until a vaccination becomes available. What makes COVID-19 significantly different in terms of the statistical analyses made with contagion and death rate with respect to other flu pandemics annually? And I think the answer there is, numerically, the number of deaths have been greater than everything except the Spanish flu of 1918. But more particularly, there is no vaccine available. Your thoughts about upcoming vaccines and timing, in particular, recently announced vaccine from the UK. Yeah, so, I think I kind of told you what I feel. I have a real aversion to academic centers trumpeting victory when they're just about to start a trial or when they've just got the first few patients in a trial. Even if you had vaccinated 20,000 patients in the last month, it would be too early for it to have shown a real impact. So I mentioned to you, we're looking at a drug called selinexor. I really hope it works, but you won't hear from us until we're sure that we have something there. So the university centers that say, we have the answer and we're starting our trial next week, are basically doing the wrong thing. They're giving false sense of security to people out there, and I'm very much opposed to doing that. Do you foresee a significant second wave of the virus as was seen with the so-called Spanish flu? I would almost guarantee that we will have a second wave. And my fear is it'll happen mostly in states like Florida, Georgia, and maybe South Carolina, which have come up for air too quickly. I'm so grateful to the politicians in North Carolina for not jumping the gun. I will comment that in Gastonia, just yesterday, it was announced that there would be liberalization and everybody would go back to work. And that has created confusion here in Charlotte because people of Gastonia are so important to both the lifestyle and economy of the rest of Charlotte. Now, I understand that the commissioner has backed down that statement, and if that's so, I'm happy about it. But every time a politician creates confusion and lack of certainty, says something dramatic that flies against the current thinking without evidence to do so, I believe it's a bad thing and it harms us. So frankly, I have a great concern that there will be a second wave. I think that the thing that I rather like about living in Charlotte, and from my friends in Raleigh, Durham, and in Winston-Salem, each of these major centers has really been practicing social distancing in a very sensible way. You just have to wander around and you see people walking their dogs with masks on. And that's going to be, I think, part of our life going forward. A question is, international travel has been impacted by COVID-19. What should we be prepared for as borders start opening up and airline travel increases? Well, it's hard for me to know how the airlines are going to approach this. There's a lot of advertising that shows people spraying and wiping and cleaning and so on, and that's all well and good. You know, at the end of the day, if you're in an airplane and it's a closed environment for 12 hours, there is the potential for recirculation of viral particles. That's why people catch colds and stuff when they've been in planes. So I think my personal opinion would be limit the travel that you do. If you are traveling, make sure that you have a well-fitted protective mask. I'm hoping that the way the airlines will approach this will be to create some distance and to ensure that they're putting appropriate filters in place, like HEPA filters, that will prevent the virus from recirculating through the airplane. And I'm sure they will talk to us about that in due course. Another interesting question, can you speak about the notion that folks who recover from the virus may still not be fully immune? Is that a myth, or do we know for sure? And the answer is we do not know for sure. I mentioned a little while ago that at the Levine, we're going to be testing our staff to see who has antibody, which means they've had exposure, and then following them to see if they pick up a clinical syndrome again. If this thing behaves like most flu viruses, there should be immunity that is meaningful for 1 to 2 years. That's why for influenza, we give a vaccination every year. So if you've had it, if this is behaving like most viruses, it should give you some protection. But being truthful, we are not yet sure. And in defense of all the medical and scientific people, you know, we've been dealing with this for only 4 months. So we haven't really had time to develop robust data about this. What are my thoughts about remdesivir and its ability to treat the virus? Well, of all the things that I've heard to date, it sounds, and this is very early, it sounds like it may be somewhat promising. Once again, the company that makes it and the investigators who've used it, I think have done a big deal. We've won kind of story. And that feels to me a little bit, and I'm not trashing them because they may have data that I haven't seen, feels a little bit like the wide receiver who throws his arms up in the air a foot before the touchdown line, and some huge tackle hammers him and pushes him back, and the arms in the air made him vulnerable to that attack. I like to see the ball across the line and on the ground without a penalty before I start dancing at home when the Panthers are playing. So I feel a little bit like we need to be sure of our data. John Gall is back on saying, do we need to move the production of drugs back to the US from China? Don't have opinion on that, John. You know, I like drugs that are produced in the USA. I know that the quality of care is solid. I don't know enough about the quality of care and oversight for Chinese production. You know, I think if the question implies, will they have coronavirus, and maybe we don't, but that's not true. We know we do. Just look at the meatpacking industry So I don't honestly have an opinion on that at the present time. There's a question here. What is your sense of the echo or collateral impacts of the pandemic in terms of delays in health maintenance, health education, screening, and so on? As months of delays pass, doesn't this set up in severity, scale, and economic impact? And that's from Don Upton. Yeah, that's a good question. And I think what I would say, we locked down in March, and Atrium is already starting to open up its scans and screens and so on in a very careful fashion. So the people that we didn't scan and didn't screen were the people where we thought there was low risk. And so I think the answer to the question is, I don't personally believe that the delay that we've had here is going to have that impact. We're already asking for volunteers at Levine Cancer Institute to work weekends in the near future. And the reason for that is, as we think about it, people are going to be trying to catch up on their economic negative factor. They're going to be trying to go to work. And so to come to the cancer center or clinic during the week might be tough for some people. So we'll plan extended hours so they can be seen in the evenings after work or at the weekends for a period of time to allow us to catch up. It will also allow us to do more work without jamming patients in together. So my sense is that given that this was relatively short term, we had a much flatter trajectory than, say, New York City or Washington, courtesy of being locked down. So we'll come out of this faster. If you go back to 2008, your question is absolutely correct. In 2008, when there was a huge economic downturn, people put off having tests done for 6 to 12 months, and that clearly had an impact with many more patients showing up with advanced diagnoses of cancer and heart disease and various other things. A question from Natasha Stambuk. Natasha, hello, nice to see you there. What do you think about the Swedish approach to managing COVID, where they've attempted to lock down only, I'm just adjusting because this question is cut off, to lock down only the especially vulnerable people and largely left society open. At least 60 to 70% of the population develop immunity by having had the disease. Yeah, you know, I think time will tell. I think it's a very high risk strategy because if they guess wrong, they will end up a little later with an awful lot of deaths. Developing herd immunity takes a while. And so while they may be right and they may have gotten away with it, my concern about the Swedish approach is it's too early to evaluate it as an experiment. There's no question that herd immunity will protect a community which is comprised of people who are being vaccinated, for example, against flu, and those who weren't vaccinated and got flu and then developed immunity. That allows a better level of protection. In the situation where we have a virus that in the USA has killed 60,000 people, and we don't have either a vaccine or a proven treatment, I think it's a risky strategy. Many people have taken the view, well, we've got hydroxychloroquine and chloroquine, and the evidence doesn't really support that they're active. There is good evidence that they cause cardiac arrhythmia. So at the moment, pending the results of remdesivir and some of the other drugs that are being looked at, we're kind of vulnerable. And so I like the idea of social distancing for everyone. I think a good example of this gone wrong, as I mentioned before, is the people who ran down to Florida for spring break, frolicked in the water, had dancing and kissing on the mouth, and then went back to their various homes and made people sick at home. I think that was a bad social experiment, and I think it's irresponsible for opening up the beaches too soon. And we've seen foolishness, even in Los Angeles, which has been really pretty sensible. There were pictures last weekend of people going to the beach and hanging way too closely together. That's incredibly dangerous as a pattern of behavior. A political question from Ranjit Rawley. How would you go about opening NC up? Would you do anything different from Governor Cooper? Well, you know, I'm blessed because I'm not a governor. I don't have all the conflicting pressures. I think he's You know, whoever is opening up in a phased fashion is trying to be responsible. You know, the idea of saying we're going to try to help the people who are getting economically killed, but we're going to encourage social distancing. We're going to make restaurants take extra precautions. We're not going to jam up restaurants with people sitting elbow to elbow. I think with the absence of knowing exactly what to do, I think that's a reasonable approach. I think Henry McMaster in South Carolina is doing some sensible things in his approach. I think he's opening it up a little quickly for my taste because his numbers are still going up. The nice thing about North Carolina is we've been flat for a while, and so it's not unreasonable at all, or sorry for the double negative, it is reasonable to be opening us up gradually. I have a real problem in Georgia where the numbers do not support it at all, and I think they're making a mistake. And I also think the sort of things they opened up, tattoo parlors, nail and hairdresser salons, bowling alleys, I mean, come on, you know, I could understand opening up stuff that is essential, and I'm not against those people making a living, but surely there's a better way of approaching it than that. So I think North Carolina is doing a responsible job generally. I'm sure we could find things to criticize, but as a big picture approach, I think it's reasonable. Is it anywhere true that this virus is a biological weapon formed in the Wuhan lab that had escaped by mistake? And if so, can there be a vaccine for it? So I think that's a good question. You know, I don't know of any hard evidence to support that. You know, I've become sort of a conspiracy theorist because life these days is so strange. You know, truth no longer means truth. People lie all over the place. We've seen so many exposés that show that so many different governments that we always thought were either good guys or bad guys have done so many things that were inappropriate. The World Trade Center, I mean, who could have conceived that a group of people would have initiated that? So I actually don't have an answer. So it's possible. I have no evidence to support it. A biological weapon isn't that special, so I would expect that a vaccine could be formed to it. But my own view is it's probably more likely that it wasn't a plot and it was more a variant of biology. Don't forget that Alex Azar and Bill Gates and many other people have been predicting for a decade that there would be a pandemic that would hit the world at some time around now. And in fact, the previous president seemed to think enough of that to develop a pandemic management office. I don't know if it actually did anything, but it's nice that we had it. That unfortunately was recently closed down, and that just left us more vulnerable. So I think, as I said, we will have a new normal, and a sensible voting public will ask its politicians, what are you doing to protect us in the future? What are you doing to protect the heroes in the future? You know, it's outrageous that my colleagues on the front line, the emergency doctors, the first responders, the ICU people in places like New York were actually exposing themselves to coronavirus of the worst type without adequate equipment. In a country like the USA, that's egregious and it's a travesty. And maybe the final question, what would be the impact on global mental health on the population in the future after a pandemic? And that's from Liddy Sergey. Well, you know, I think that's a very thoughtful question, and I don't know. I would comment that some of the best that I've seen in our society has shown itself in the past weeks. People being kind to each other, people donating to each other, people supporting and helping each other, people showing courage. I've been incredibly impressed here at Atrium Health with a number of chiefs like myself who are still here frontline with their troops fighting this thing. You know, men like David Calloway who put themselves at risk every day that they're in the emergency department or in the intensive care unit, and understanding they have protection. But, you know, the impact of that courage, it shows fineness. I think if anything, one of the spin-off benefits is the gloriousness of and courage of all our first responders, the nurses, the frontline staff, physicians, letter carriers, people who work in grocery stores, the police, the firefighters, all people who've taken risk in order to maintain our society. So I think all of that population, once this is over, will come out of it feeling good. I will say, I think most of us in that situation don't feel so good about the fact that people have lied about the availability of equipment and have made up stories about how this isn't a serious challenge. I think we'll remember that a long time, personally. But from the point of view of mental illness, I think the bad side is people have emphasized the importance of physical illness and kind of downplayed the immense trauma of mental dysfunction. And there's been more support directed away from mental health, and that's a bad thing. I heard a very sad story just a couple of days ago about an emergency room physician in New York City who seemed like an unbelievably good human being, got coronavirus while working in the emergency department, went home, got quarantined, was cleared, came back on the line, and was overwhelmed by everything and committed suicide. I think that just reminds us how important mental illness is and how seriously we should take it and not forget about it in the context of dealing with a new challenge to our population. So I think at that point I should hand back to my long-term friend and colleague LJ Stambuk for closing remarks.
Thank you so very much, Derek. This is a great session where we learned a lot about what's happening here in Charlotte, what's happening around the world, and especially the efforts that you have at LCI and Atrium Health to be on the front line and help our families, our community get through this very distressing pandemic. I do want to bring to your attention all the people that are attending that we do have Atrium Health Back to Work virtual town hall meeting on Wednesday, May the 6th from 3 to 4 p.m. Once again, Atrium Health, our partner, has Atrium Health Back to Work virtual town hall on Wednesday, May 6th from 3 to 4 p.m. And I would advise you all to participate and learn more what is happening next week. Next week, we have on Tuesday, May the 5th, we have the Distinguished Speaker Series with Brent Cagle, who is the Aviator Director for the City of Charlotte. The topic of his conversation is Flying the Pandemic Skies. Very interesting. We'll learn more about travel, what's happening. On Thursday, next week, a week from today, on May 7th, we have the World Affairs Council Distinguished Speaker Series with Philip Kogan. He's the Bart Lilly columnist at The Economist of London, and he's going to speak on the hard work of strangers, a globalized economy. And we are interdependent, interconnected. This pandemic shows us that we're part of one world and we need to work together to get through these difficult times. It was such a pleasure, Derek, always, and thank you for taking time out of your very busy schedule to talk to us. Dr. Raghavan, a big round of applause to you. Thank you very much. Hope to see you soon. Take care. Bye-bye.